Good evening from Rocky Mountain PBS. I'm Cynthia Hessin. This is Colorado State of Mind. Tonight, the next installment of the iNews at Rocky Mountain PBS series, Losing Ground, on the decline in social and economic equality in Colorado. In part 2, we'll see what has happened to health care. And here to tell us more is Kevin Vaughan, senior reporter at iNews, whose name you may recognize from his years at 4 Colorado newspapers, including the Post and the News. And at the News, he was also a Pulitzer Prize finalist. Kevin, as we look at this headline about the health portion of Losing Ground, the main thing is the infant mortality. It just jumps right out.
It did jump right out. What we found looking at state health department data is that African American babies and Latino babies are significantly more likely to die in the first year of life in Colorado than white babies. And the numbers are sort of shocking. An African American baby is 3 times as likely to die in the first year of life as a white baby, and a Latino baby chance of dying in the first year of life is 63% higher than it is for Caucasians in our state.
And you said that overall, the white mortality rate in Colorado is better than the national average?
Yes. White residents of Colorado experience an infant mortality rate that's a little bit lower than the national average for whites. And at the same time, Latinos and African Americans in Colorado experience an infant mortality rate that's higher than the national average for Latinos and African Americans.
How striking all of that is. Let's take a look at some of the other statistics that you came up with and other information in this video by Joe Mahoney of iNews at Rocky Mountain PBS.
My name is Dr. Carolyn Chen. I'm a family physician and I work at Clinica Family Health Services. I think it's devastating that we have such a difference in the rates of health. You know, it's a very difficult and interesting and complex question why there's so many health disparities amongst people of different ethnic backgrounds. A lot of it has to do with socioeconomic strata. Our patients have real barriers to be able to get health care. If it's snowing, and I have a pregnant mom who lives about 1.5 miles away and was extremely pregnant and had 2 other kids with no close family, then she walks here with her 5-year-old walking in the snow, her pregnant self, and her littlest one so far in a stroller. And so if they can't access care because of the weather, the transportation, financial barriers, then there are real reasons that are not excuses for them not to have come to the doctor. And unfortunately, we find those more with people of lower socioeconomic status. Sorry. There are many things that need to be done so that healthcare disparities can be lessened. The number one barrier to that, no matter whether you're a child and largely insured, is to have a medical care provider that you know and that you trust. So some people would argue that that means that everybody should have health insurance, but everybody has to have access to a healthcare provider that they know and trust. I think the relationship, a trusting relationship, is really important. So not only have I seen Isaac through his entire life, I've also cared for his mother for the past 6 years, and I cared for his older sister who's now 4, and I'm also the primary care provider for the father of the family. And so having that knowledge as a family doctor is, I think, distinct and very special for me. A country like the United States should be doing better at this, and we have a lot to learn in healthcare, and we're trying actively to learn how to have our health rates be the best in the world, like I believe that they can be.
Losing Ground is a major effort that was put together by the iNews team by looking at a great amount of data that goes back into the 70s. Is that right, Kevin?
Data all the way back to 1960 for things like home ownership, education, family income. I specifically looked at health data compiled by the state health department that goes back into the 1980s across a host of measures, life expectancy, various diseases, and how that affects different populations of people in Colorado.
Diabetes is one that we know just before you even start talking about ethnic groups. That's a big concern in this country over the next 20 years or so. What did you find about racial and ethnic disparities there?
Well, again, as with infant mortality, Latinos and African Americans are much more likely to experience diabetes, to die of diabetes, than whites in Colorado. And as with some of the other measures, you see signs of good news, and yet that good news is tempered. For example, the death rate from diabetes for African Americans in Colorado has been declining in recent years as a result of a host of things, healthcare and education and lifestyle changes. But at the same time, it's been declining faster for white residents of Colorado.
That's very interesting. Even cancer, you say, can certainly be different in those two populations.
Absolutely. Different kinds of cancers affect different kinds of populations. But again, some things are stark and jump out at you. An African American woman who contracts breast cancer is more likely to die from that disease than a white woman who contracts breast cancer.
And is that because the average African American woman we might be talking about here doesn't have access to get mammograms and so forth?
Well, it's complicated, and like all of the stuff that we looked at in Losing Ground, it's all bound up and wound around all kinds of factors. When you're looking at health, you can talk about access to health care, you can talk about things like education. People in poverty, for example, are more likely to not be educated about things that affect health that may not strike us as sort of health issues. For example, there was a study done recently by a Harvard professor that looked at things like seatbelt use and bike helmet use among fifth graders in cities around the country, and found much higher incidences of those of their use in higher educated, higher income populations, and of course conversely lower use of those things among people in poverty and among people of color in poverty. And so you might not think that a bike helmet is per se a health issue, but it is a health issue because a child wearing a helmet is less likely to suffer a serious head injury if they crash than a child who's not wearing a bike helmet.
It seems surprising to me that through education that kids should get in elementary school, or that they even peer education of them wearing bike helmets, why would that not be as true for Latino and black children as it is for whites? I mean,
some of it is really wrapped up in families and communities, and if you think about where you grew up, where I grew up, and what sort of the norms were in your neighborhood. If you grew up in a neighborhood where kids don't wear bike helmets, is the kid going to listen to the safety expert at their assembly at school that lectures them for an hour on a bike helmet, or are they going to look at their friends that are riding up and down the streets without bike helmets and conform to that group?
And especially, I suppose, if your mom doesn't have the money to buy you a bike helmet, then you're going to go without one as well.
Could be an issue, sure.
What else struck you as you were reporting this story, as you got started doing it or decided which directions to go?
Life expectancy is another one. A white person in Colorado on average now lives about 3.5 years longer than an African American person in Colorado. And the Latino life expectancy in Colorado, after climbing a decade or so ago to within just a real small fraction of the life expectancy rate for Caucasians, has declined in recent years. And, you know, if you look at a host of different diseases, stroke, we talked about diabetes, and some of these other ailments, they affect minorities disproportionately in this state.
Kevin, this is fascinating, and I want to direct everyone to the whole package of the Losing Ground story, which you can find on our website at rmpbs.org/losingground. Kevin Vaughan is with iNews at Rocky Mountain PBS, and next week we will come to part 3 of Losing Ground when we focus on the changes in the economy over the 40 years that we have come through. Right now we are going to continue our focus on health with our next guests. Healthcare availability and access are not equitable over the many types of communities and populations in this country. This week, the Colorado Trust brought to Denver Dr. Paula Braveman, a leading national expert on this topic, and joining us as well, health reporter Michael Booth from the Denver Post. Dr. Braveman, you are at the Center for Social Disparities in Health at UC San Francisco. How do you measure and keep track of this gap there?
Well, my group has our main expertise technically is in the field of epidemiology. So we use epidemiologic methods. We work some with data sets that already exist, analyzing different national data sets, a lot of them coming from the National Center for Health Statistics. We do a lot of work in collaboration with the state health department in California, and partnered with the state health department in developing, maintaining an annual survey of maternal and infant health. And we use the data from that survey a lot to take a look at issues of health disparities and health equity.
So you have a body of data that you can look at that goes over a few years, I'm sure.
Yes, yeah.
And what have you seen happen?
Well, what we've seen happen in California, and unfortunately it's paralleled in national data, and from the very little bit that I know about the situation in Colorado here, is that in many cases the disparities, the gaps between groups by race or by their socioeconomic status they've either stagnated or in some cases they've actually widened, and this is very disturbing.
Dr. Braveman, can you talk a little bit about the main conversation in healthcare right now is about the Affordable Care Act and how that may or may not expand access to health insurance, at least for wider groups of people than currently exist, including many of the minority groups or just subsets of populations that you've studied where access is not as strong as it should be. But you have also talked about how there's a difference between health care and overall health, and that they're not always the same thing. Do you feel that the Affordable Care Act and bringing at least insurance to a wider groups of people will start to address some of these gaps that you've recognized in your work? I do. It doesn't go far enough for a lot of us, but I think it is a step ahead, and it will mean that a fairly significant proportion of people who now do not have access will have access. But you're absolutely right that I like to make the distinction between health and health care, and I think this is a theme throughout the work of my center, that there's been an accumulation of knowledge, particularly in the last decade or 15 years, that really tells us that we can't expect to achieve better health and to close the gaps in health between groups solely by focusing on health care, that the conditions in which people live, learn, work, and play are probably the most important factors in determining who gets sick in the first place. So once we're sick, medical care is what you want, no question about it. But too many people are getting sick that do not have to, and it's because of living and working conditions. What would some of those specific conditions be that shows a difference between groups of people who are not living in the same conditions? Poverty would be the big one, and a lot of the conditions that are associated with poverty.
child care, quality child care that is stimulating the cognitive, neurologic, emotional, and physical development of a child so that that child is school ready when the time comes to go to school, and then that child can do well in school, complete an education that will permit them to get a decent job with decent pay and with health insurance, and to buy or rent a home in an area that's healthy for them and for their children to live in. Those are the kinds of factors that I'm talking about.
So it's all very holistic, really, to try and look at the solution?
Yeah.
I noticed that, I'm sorry, go ahead.
Well, just I was going to say, you may have heard about a report that was released just a few weeks ago from the National Research Council and the Institute of Medicine, which are quasi-governmental bodies. And this was a report showing the significant health disadvantage in the U.S. compared with other affluent countries. So I was one of the authors of that report. I was on the panel that authored that report. And we felt, although we couldn't say from the results, we couldn't say, this is what you need to fix. If you just do what we tell you, this is going to fix everything. Here's this one thing. We felt that we could shed some important light on the issue and to say that probably the fragmented and inequitable healthcare system, probably that's part of it, but it's not the whole thing. And that other places to look were in the area of poverty, especially child poverty. We're the top among all affluent countries. We have the highest rate of child poverty. We have among the lowest rates of children in formal daycare and formal institutional preschool. We have the weakest social safety net. That we couldn't say these are the things, but we looked at the whole pattern and said these are reasonable places to emphasize in the research. And it's probably worth my adding that we've known for a while that the U.S. has been at or near the bottom among affluent countries in infant mortality and in life expectancy. But at least in the health field, we've known that. What this report found that I think was really shocking was that when you look at scores of health indicators across every age group, that the U.S. is at or near the bottom among the affluent countries on almost every health indicator. There are a few exceptions. And
that is astounding.
It is astounding, but then when you look at what some of the differences are between our country and theirs, you do look at the fragmented healthcare system that doesn't cover everybody, and you look at the poverty and specifically the child poverty, and you look at the lack of a social safety net and think about the insecurity that can come with that. And I think one more issue that's worth emphasizing, because I think this is very relevant to where we started, that we looked at data. We asked, well, if you just look at whites, are you going to see the same finding? Yes. And even more, that I think that wasn't surprising to those of us on the panel. But what was surprising is that in some studies, well, in the studies that have looked at this, even affluent people in the U.S. do have worse health than equally affluent people in other countries. And in a couple of studies, affluent people in the U.S. had worse health than lower socioeconomic status people in some European countries, in the UK specifically. So something is really fundamentally wrong, and the pattern, as I say, you can't explain the whole thing with our limitations in access to health care.
What do you see as some of the main contributing factors in something like infant mortality, which we've been talking about today? What are the factors that can prevent that kind of infant mortality that we know work, whether it's a healthcare solution or some other kind of larger cultural solution, that can address that in the first few months of life? We've talked about school-based healthcare or school poverty, but infant mortality really addresses those first few weeks, first few days, first few months. what are some of the factors that can improve that in other societies?
It's a great question, and it's a tough one, because we probably don't know more than we know about it. I think once the child's born, we know what influences their likelihood of survival, and the medical care is the big thing in the first 28 days after birth, being at a hospital that has adequate facilities for neonatal intensive care. And then after that, for the rest of that year, it's really the socioeconomic environment in which that child lives and their exposure to injury. Those are the big issues. But the main driver of infant mortality is what we call in the field poor birth outcomes, and by that mostly we're talking about low birth weight, so a baby being born too small, or premature birth, baby being born too early. Those are the biggest drivers of infant mortality. And
low birth weight is addressable, isn't it, if the mother has the right prenatal care?
This is what we used to think. And it's one of the reasons why I made a shift in my own research from studying the dynamics of access to prenatal care, of disparities in prenatal care, to saying, I want to study the actual health outcomes, and say what could be driving those, the disparities in those. And a lot of evidence has accumulated that does not really show, in good studies, does not really show that prenatal care makes much of a difference for low birth weight or premature birth. It's important.
Yes.
It's important for the health of the mother. And it's possible that the studies that have been done just haven't been done well enough to show something that's there, but it's pretty convincing when you look at that data, and that has forced a lot of people, including myself, to say, well, what's driving low birth weight and preterm birth? And there's actually very little that we know about that. We know that smoking matters. That's a very big one, but that doesn't explain the disparities by race, because African American women smoke less than white women do.
It's so interesting to have this bird's eye view from 40,000 feet. Michael, in your reporting recently, you were talking about how you reach the people who will not be covered in the Medicaid expansion or whatever.
Yeah, and Dr. Braveman's research is really interesting regarding that, because we've shown that there are almost 400,000 Coloradans who will still be without health insurance, even when all the aspects of healthcare reform from 2010 are in place. Large group of them are undocumented residents of Colorado. Large group are people who do not make enough, but can't to make too much for subsidies, but don't make enough to actually afford health insurance themselves. So 400,000 people is still a significant number in a place like Colorado. But figuring out how to reach that group that could get some kind of subsidy or could sign up for Medicaid, but have been unreachable through any number of means for a number of years, is one of the things that people are going to have to be talking about. And groups will be doing all kinds of publicity, marketing research, focus groups, trying to figure out how do we get the people who can walk in the door to actually walk through that door. And what Dr. Braveman is saying, apparently, is that we're not even sure yet about some of the factors that might influence health the most. So it seems that there's a lot of research left to be done, even before you start marketing to that group, about what it is you want to offer them once they do walk in the door that would make a difference in their healthcare outcomes. What services do we need to provide if it's not just a prenatal visit? What else do we need to do to make sure that that health outcome is better?
And I think we do know enough to say that a whole array of healthcare services are associated with better outcomes. And prenatal care is important for the mother. I mean, so not going to get into the complexities with people saying, I can't guarantee you that's going to make a difference in the birth weight or when the baby is born, the timing, but that's important.
Right.
But
it's better than
is
not
important
getting
too. Right. And so I think that the questions, I always, when I talk about this issue of health is more than health care, I don't want to downplay the importance of health care, because I think, as I commented a little earlier, when you're sick, health care is what you want. But what we've learned, and there really is just now a huge evidence base that's accumulated around this, that what determines whether you get sick or not in the first place are the social factors, like poverty, for example.
So one movement that's going on in Denver, I'm sure it's going on in other cities, is there are a few schools that offer breakfast in addition to lunch. And there's a movement to try to get all of the Denver public schools, for example, to get access to that federal funding that's out there and make sure that there's a breakfast program as well. And I'm sure that's one of the factors that may contribute.
Absolutely.
Okay.
Absolutely.
I'm so sorry that we're out of time for this week's Colorado State of Mind, and that is our program. Thank you very much to Dr. Paula Braveman and to Michael Booth of the Denver Post. You may see this program again at video.rmpbs.org. Next week on Colorado State of Mind, Part 3 of Losing Ground and a preview of the upcoming Vail Global Energy Forum. Hope you'll join us for that, and thank you for tuning in tonight. I'm Cynthia Hessin.
We have one of the lowest life expectancies here, unless you're 75 years old. And if you have made it to 75, then we have one of the best life expectancies for those who get there.
Not coincidentally, because Medicare kicks in at 65 and everybody gets health insurance. There's not a complete overlap in those issues, but that's one of the reasons.